The broadcast is now starting. All attendees are in listen-only mode.
Good morning.
Hello, everyone.
Good morning. I will start with the introduction. Good morning. My name is Milka Dinev. I am the backstop for the Maternal Health Supplies Caucus of the Reproductive Health Supplies Coalition. Welcome to this new webinar organized by the Maternal Health Supply Caucus. You are all muted right now, and in order to prevent background noise from your computer, we have had to close all the microphones. This webinar is being recorded, and a link to the audio and video will be sent to all members of the caucus in a couple days. We will not open the microphone during this webinar, but you are most welcomed and encouraged to write your questions in the question box of the GoToWebinar platform in your computer. We're very lucky this morning or this afternoon to have Doctors Chimesi Anyakora and Dr. Chioma Ejekam from Nigeria. Dr. Chimesi Anyakora is the Chief of Party of the Promoting Quality of Medicines Project of USAID and US Pharmacopoeia. Dr. Chioma Ejekam is a professor at the University in Lagos, and Dr. Ejekam is the principal researcher in this work. It is now my honor and pleasure to present Dr. Chimesi. Dr. Chimesi, the microphone is all yours. Please go ahead.
Thank you very much. Good morning, everybody. And for those in Nigeria, good afternoon. And for others, good evening. Welcome to our presentation. Today, we're going to be talking about oxytocin quality audits and clinical experience in Nigeria. These are two different but related topics which we have been working on in the last 2 years. In 2016, we did a survey of oxytocin quality in Nigeria. As a follow-on to that study, we also did a clinical experience of healthcare providers in Nigeria. I will be presenting the first part of this study, while my colleague Chioma will do the second part. Poor maternal and child health indices have remained a recurring health challenge in Nigeria. Every single day, we have 145 women dying due to childbearing issues. And in 2015, the WHO reported that Nigeria and India combined contributed to more than a third of the global death due to maternal mortality. And in Nigeria, postpartum hemorrhage is the leading cause of maternal mortality. This is also the case with so many other countries, low and middle income countries. WHO has strongly recommended oxytocin as a safe, effective, affordable drug of choice for preventing and treating postpartum hemorrhage in the third stage of labor. Also, this medicine is indicated for induction and augmentation. Now, but the situation is that oxytocin is a very unstable compound. And in most third world countries, the infrastructure required to keep oxytocin in good condition is almost all the time lacking. For example, Nigeria is classified by WHO as a Zone 4B region, which means that we have temperature ranging between 25 plus or minus 5. But in reality, we have temperatures much above this. So it has become a serious challenge to keep oxytocin at the recommended storage condition. In most low-income countries, the healthcare systems are very, very weak. And when these are combined with the issues of poor quality medicine, it becomes even more disastrous. And most healthcare workers somehow do not link poor health outcomes to quality of medicine. And that has been an issue. And that's one of our motivations for carrying out this study. And also, in most countries, there is very limited data on epidemiological studies due to poor quality medicine. We cannot overemphasize the importance of good quality medicine. Poor quality medicine has the greatest potential for harming the health of consumers with far-reaching consequences, including prolonged sickness, treatment failure, drug resistance, side effects, economic hardship, and death. And in the case of oxytocin, most times healthcare workers resort to surgical procedures because of failure of this medicine. In this study, we've tried to look at the quality of medicine across Nigeria, also across Nigeria. The first part of this study, of this presentation, will be on the quality audit of oxytocin. With our methodology, this survey was a descriptive cross-sectional survey using simple stratified random sampling performed in 6 regions of Nigeria. Nigeria is a fairly big country with 36 states and over 180 million people. The country is divided into 6 regions: the South-South, the Southeast, the Southwest, the North Central, the Northeast, and the Northwest. All these regions are a bit unique because they have their unique microclimatic conditions and also some peculiar social and economic leanings. So in this study, we made sure we captured every part of the country by sampling from each of these states in the regions. Also, for the purpose of this study, we classified the supply chain of oxytocin in Nigeria into 6 levels. Level 6 was for Federal Medical Center warehouses. Level 5 was for state hospital stores. Level 4 was primary healthcare centers. Level 3 was midwife clinics. Level 2 was wholesale and retail pharmacies. And level 1 was patent medicine stores, or PPMVs. It's good to note that PPMVs are not supposed to stock this medicine, but because of the chaotic situation of medicine distribution in Nigeria, we try to include them in this survey. All the samples collected were maintained in the cold chain from the point of collection to the time of arriving at the lab. We subjected all samples to both microbiological and physicochemical tests. The tests carried out include HPLC assay, field volume, sterility, pH, and bacterial endotoxin tests. A total of, based on our sampling method we use, we identify the minimum sample required to do this survey. A total of 159 samples were collected. Each sample was made up of 40 ampoules of oxytocin, because this was the number required to carry out all the tests we needed on this sample. All the samples were subjected to verification of their status, and they were all registered in Nigeria. All the samples also passed, or rather fell within the range for sterility, for pH, for field volume, and for bacterial endotoxin tests. But 74% of the samples collected failed HPLC assay, which should be between 90 and 110, as indicated by USP 39. Altogether, going into details of these results for different regions. Southeast had over 93% failure. Northeast had 85% failure. North Central had 76% failure. Northwest had 64% failure. Southwest had 60% failure, while South-South had 57% failure. Altogether, it's good to note that these failures were not in line with the temperature of these regions, meaning that it's not just the temperature, it's something bigger than that. Also, we try to aggregate our results according to the health facilities or the levels of supply chain of oxytocin in Nigeria. For the patent medicine stores or PPMVs, as expected, we had 95.7% failure. Almost everything failed. For midwife clinics, we had 80.6% failure. It's good to note that this is a point of care that pregnant mothers walk into these clinics. Pharmacy had 70.2% failure. State hospitals had 70% failure. Primary health care centers had 63.3% failure. Federal medical centers had 62.5% failure. It's also good to note that at the point of collection, we try to find out the temperature of storage of these medicines. 98% of the samples collected were stored above the recommended 2 degrees to 8 degrees in all of them. And pharmacy stores seem to be the best in storage. Based on the result of these findings, we carried out a second survey, clinical experience with the use of oxytocin by healthcare providers. And at this point, I will let my colleague Joma take over.
Hello and good evening, everybody. Good evening, Nigeria. Okay, like Chimeze just said, this is a sequel to the first quality audit done on oxytocin. And the purpose of this clinical experience with use of oxytocin injection by healthcare providers in Nigeria, where the purpose was first, to know what healthcare providers know about oxytocin injection. We wanted to know how they use the oxytocin injection, their pattern of use. Then assess their clinical experience with the use. Do they perceive if it's effective or ineffective? That was what we wanted to find out. If they had any suspicion of the different brands that they were exposed to in their daily practice, did they have any suspicion of effectiveness or ineffectiveness, which would be evident by the kind of dose they use and the indications they were used for. So it was a descriptive cross-sectional study carried out in 2017. The minimum required sample size was about 500, but we had 705 healthcare providers. Our study population were doctors and nurses who had been trained or experienced in the use of oxytocin, registered healthcare providers in either the public or private healthcare facilities that offer obstetric and gynecological services. We used the multi-stage sampling technique to select these healthcare providers across the 3 different health levels of the health system. The tertiary level, where you have the teaching hospitals, the secondary level where you have general hospitals, and the primary level where you have primary healthcare centers. So at the end of the study, we recruited doctors and nurses from 195 health facilities, 10 general hospitals, 3 tertiary health facilities, 10 general hospitals, 32 comprehensive primary healthcare centers, and 150 private healthcare facilities across the 5 administrative divisions of Lagos State. And I just want to explain why the comprehensive beside the primary healthcare centers. Comprehensive because that is, we have primary healthcare centers, we call flagship centers. This is where oxytocin, they offer a level of emergency obstetric services. So this is where the primary healthcare facility where oxytocin is expected to be used. And we collected data quantitatively using a pre-tested self-administered questionnaire. We sought information on the respondents' social demographic characteristics, their occupational history, wanted to know how long they have been in practice, what they knew, their general obstetric knowledge around oxytocin and the postpartum hemorrhage and management, then their clinical experience with the oxytocin they use. So our findings were interesting. Most of our respondents were in around the 30s age, and there were more females and more nurses. About 62% of them were from the private sector. Almost 65% had 1 to 10 years of work experience with a median of 7.5 years. Almost all the respondents have had some form of formal training on oxytocin use. 86% of them knew the correct definition of postpartum hemorrhage. Interestingly, just over half of the respondents knew the proper storage of oxytocin, which was supposed to be between +2 to +8 degrees centigrade in the refrigerator. And of this, of the whole respondents, of the doctors that participated in this survey, only 58% of doctors and about 47% of nurses knew the proper storage place of oxytocin. This graph is presenting the results or the findings. We assessed here what respondents, the indication for use of oxytocin. We assessed what they often, what do they use oxytocin for? Most commonly in their practice, what do they use oxytocin for? That's the indication for use. And we found that about 51% use it for stimulation of labor, about 68% for induction of labor, and as much as 80% for augmentation of labor. And in the introduction, Chimeze, my colleague, mentioned that oxytocin, yes, is primarily used for prevention of postpartum hemorrhage, fine. But again, used intrapartum, but where benefit outweighs risk. And findings and in literature, it's been reported that there is high, excessive, and inappropriate use of oxytocin intrapartum, especially in low resource settings, which often leads to unnecessary or unwarranted surgical procedures. And this is kind of pointing out here because there is high use of oxytocin intrapartum. But here too, about 78% of them use it for management of postpartum hemorrhage. Again, this graph tries to present the results of assessing the knowledge of proper storage of oxytocin. It's showing again here that just about 52% of the respondents knew the proper storage of oxytocin in the refrigerator. Now, this table tried to assess, we wanted to know the dosage of oxytocin used for various obstetric indications. So we asked respondents to assess what they use, their dosage for use, maximum dosage for stimulation, that's intrapartum use of oxytocin in primary paras, their maximum dose intrapartum for multiparas, and for postpartum hemorrhage management. And from here, we can see that, but by the way, I would say that in literature, like most of the recommendations, UK, US, Canada, would recommend intrapartum use, they say low dose, or let's say 5 international units. And WHO recommends 10 international units of oxytocin for management of postpartum hemorrhage. Here we can see that about 48% use 10 international units for in primary paras, and 41% use that in multi-paras. And also 17% use as much as 20 international units in primates and 10% in multiples. If you get to management of postpartum hemorrhage, or more than 40% use 20 international units for management of postpartum hemorrhage, and as much as 10% use doses ranging between 30 international units and 60 international units. There's also record in literature that documented that healthcare providers in sub-Saharan Africa tend to use 2 to 3 doses of vials of oxytocin to achieve the desired effect of one. And if you translate this, a vial, most times the vial come in like 5 international units or 10 international units. So if we take like the 10 international units, applying it here, it will come to like about 3 to 6 doses, vials to achieve the effect of one. And what we wanted to do here is just to characterize what they experience with the use. So this shows apparently that they tend to increase the dosage to achieve the desired effect of uterine contractility, which is primarily the function of oxytocin to achieve uterine contractility or stimulation, to achieve uterine stimulation, which can lead to cervical dilatation if there are no other obstetric indications or challenges. Then this pie chart, is again showing the findings of the management of postpartum hemorrhage, where about 10% use doses ranging from 30 to 60 international units, and about 41% use doses about 20 international units for management of postpartum hemorrhage. 33% use about 10 international units. Here, this table, in summary, we had about 12. We assessed 12 brands, commonest brands of oxytocin in the Nigerian market. We had some from the quality audit that was done before this study, and we assessed the market for the commonest brands that are available for the obstetrician or the healthcare providers to use. And respondents were asked to take their experience with each brand, effective, ineffective, I do not know, or I haven't used that before. So a summary of this, assessing each of the brands, is what we summarized here. You can see here that perception, because there's already an objective analysis, which is the assessment done, the quality audit. This is an assessment with their perception, because you must have a high index of suspicion. So where we assessed what they think about a particular brand, and there were 12 brands that were assessed. So by extension, this is a multiple response, so we don't expect to have 100%, a totaling of 100%. Every person may have experienced a particular brand or different brands being effective and would have some other brands they have experienced as ineffective. And it's interesting to know expectedly that as much as 98% fine would have experienced a brand of oxytocin. But it's very important to know that as much as 13% of these respondents have come in contact with an ineffective brand of oxytocin that were consciously, they knew this brand wasn't ineffective in the course of their practice. So this is just a summary of most of the results we've presented so far, where we talked about the 62 of our respondents being from the private sector, 86% knew the correct definition of postpartum hemorrhage, 13% perceived ineffectiveness of oxytocin, and about 52% knowing the proper storage of oxytocin. In conclusion, we found that our findings are suggestive of high level of substandard oxytocin injections, and of course, knowledge of proper storage of oxytocin. As much as the 52%, and we know that most times knowledge would affect practice. And of course, by the time you go in the radar, with knowledge, practice is often less. So expectedly, if we had assessed on-site storage with this group of people, we expect, of course, something much less than 52%. And again, the storage conditions could be a possible source of this level of failure because oxytocin could rapidly degrade, following with what Chimete had presented in the quality audit. You agree with me also that our findings agree with what has been reported in other studies in low and low resource settings, that there is excessive, inappropriate, and inconsistent use, including varying dose administration. We found out that even within facilities, people tend to use different doses. There isn't any unified protocol for use of oxytocin. And you will agree with me that with oxytocin, with oxytocin, which is may have likely led to this spuriously high perception of drug effectiveness among respondents, because they do not suspect the drug and they keep increasing the dose. If 10 is not effective, increase to 20, 30, 40, 60. It made most of the respondents or healthcare providers not suspect drug ineffectiveness until they get to a 60 and achieve what they want to achieve. The drug has worked, forgetting that there is a recommended dosage. So this may have led to the spuriously high perception of effectiveness, which we got at 98%. So we suggest continued training of healthcare providers in medicine safety monitoring. And again, what we want to achieve in this whole study is to awaken our consciousness to begin to think that, remember that medicine's quality is a contributor in the chain of events that could predict disease progression or poor health outcome, and is obviously now a contributor to, it will be a contributor. Maintaining medicine's quality will be a contributor to reducing our maternal health risks in Nigeria. Thank you for listening, and we're ready for questions.
So thank you very, very much, Doctors Chimezie and Chioma. This was an excellent presentation, and I am sure that everybody who's here, we have almost 50 people in the webinar, are extremely pleased with all of this new knowledge. I will start reading the questions, and you decide if Dr. Chioma or Dr. Chimezie will respond. The first comment and question comes from Kabir Ahmed. Kabir is he was one of the chairs of the Maternal Health Supplies Caucus, and he used to be with UNFPA. He's now in private consultancy. So Kabir is asking, our experiences joint WHO, UNFPA in 5 countries. Sorry, this is moving.
I'm sorry. Okay. Our experience, joint WHO-UNFPA 5-country studies in 2007-2008 found that such studies conducted on the ground, taking MOH policymakers, regulators, and other key stakeholders is good, and afterwards there should be a joint work plan steered by the MOH and key in-country stakeholders with allocation of some resources and a follow-up mechanism which has been very effective. My question is, have you doing something like this with this study? Are you planning to do something like this?
Yes, we actually, a few weeks ago, did a dissemination of the study, and many top-level stakeholders were around. As we speak, the Minister of Health of Nigeria is considering the report of this dissemination. So we are actually doing something. Thank you.
Okay. Let me go to another question. Erica Badelman, thank you for this very interesting and important work. Could you comment on any differences between the public and private sector facilities for both the oxytocin quality and provider awareness?
Yeah, I will do the one of quality. Chema will do the one of healthcare providers. Yes, in general, there's a lot of failure. But what we found out was the pharmacy outlets, they tend to be more knowledgeable on how to store oxytocin. But in this survey, we found 98% of all the samples collected, the storage condition were not correct. So it's a kind of general lack of effort to store it at the right conditions, but private pharmacies did much better.
Okay, this is Chioma. For the healthcare providers, public and private, the healthcare providers from the public they were better with knowledge. About 68%, they had better knowledge compared to the private healthcare providers from the private healthcare facilities with knowledge. Then perception of the oxytocin, the effectiveness as well. Our findings were better because we had to do some statistical association as well. They were significantly different, and they find those of the public were better than that of the private. Thank you. So the next question comes from Per Kronslev. Has it been discussed to let the oxytocin... Oh, this is the process of publication, so definitely. Sorry, Dr. Choma, the next question. Has it been discussed to let the oxytocin be in the vaccine's cold chain? May this work be a ticket to discuss that?
As a matter of fact, NAFDAC, Nigerian Regulatory Authority, is doing a lot on that direction. Also, there is a manufacturer in Nigeria, at its own initiative, is trying to develop a unique cold chain to make this happen. But at government policy level is being considered strongly, and hopefully very soon that will be implemented. But what we found out was a general lack of knowledge among everybody, policymakers, regulators, practitioners, everybody. So we believe that this is really a landmark study that will initiate a lot of policy changes in Nigeria and also maybe in other countries, so that we see a reduction in death due to postpartum hemorrhage, because from what we are saying, we can link that high mortality to the medicine quality. Because if this high level of quality medicines are of poor quality, it means that those who walk into the hospitals go there and receive poor quality medicine that will not have any effect on their health. Thank you.
And it might be good at this time to mention that there is a joint statement by WHO and UNICEF, where both organizations strongly recommend that oxytocin be included in the expanded program immunization cold chain, in the vaccine cold chain. So we have international guidance from WHO and UNICEF to include oxytocin in the cold chain. So in the future, if any of you require more proof of this, you can always contact me and I can provide you with this statement. Then we have another question from Kingsley Odokwu. Are there any heat-stable oxytocins? What do you say, Dr. Chimesi? Hello?
Can you come again? We didn't hear that question. Can you come again, please?
Sure. Kingsley Odokwu is asking if there are any heat-stable oxytocin. I can answer that question, no?
I can't get the question. Sorry.
Are there any heat-stable oxytocin?
I put the speaker on.
Can you hear us?
Okay.
No, there is none.
Okay.
Yes. There is no heat-stable oxytocin in circulation. And when we sampled, we didn't find any. And none is registered with NAFDAC. Yes.
Exactly. And even the Maternal Health Supplies Caucus is now starting a campaign where our tagline is buy quality, good quality oxytocin and keep it cold. So we are starting an international campaign. We have developed a messaging framework and we're going to be sharing it with all the members of the caucus so that everybody knows that there is no heat-stable oxytocin, even though some inserts and some labeling in the boxes say that the oxytocin is heat-stable. I have another question from Titilola Duro Aina. Thank you for a great job. I observed over 90% of the providers had been trained on oxytocin, yet just about half of them knew the storage conditions. Would continuous monitoring of healthcare providers to adhere to storage standards not be more effective than endless training?
Yeah, you are right. Yes, most times the trainings are not as effective. I think in the future, we have to recommend that beyond just the training, there should be a kind of monitoring method to make sure that it's effective. They try to use the recommended storage condition.
Okay. Yakubu Aliyu is asking, thank you for the excellent presentation. Have you considered the differences of storage at the PHCs and the secondary health facilities?
Yes, we did. At each point, we tried to check the condition of storage. As I said, 98% of the samples were collected in conditions that are not the right conditions. So most people were not able to store their products between 2 to 8 degrees. for several reasons: lack of knowledge and also not having the infrastructure needed for it to happen. Thank you.
I have another question from Titiola. What other reasons, aside from storage, will you say accounts for the poor quality of the oxytocin? Because though the pharmacies have the best storage condition, according to your presentation, the quality of oxytocin is poorer than those in the secondary facilities and the federal facilities. What other reasons aside from storage? Dr. Chimesi, you're there? Hello? Yep.
Hello. Okay. Yes. For several reasons. One is we don't know what the coach is before you go to this. Secondly, oxytocin can stay outside that temperature for a few days. In fact, WHO says 30 days. So we don't know the answer, but we know that it's not just about how you store it at the point of collection, but the whole supply chain. So maybe it got to them. Hello?
Yes, we can hear you.
Hello?
Yes, we can hear you. Hello, we can hear you. We can hear you. Hello?
Hello?
Yes, we can hear you.
Hello?
We can hear you. We can hear you, doctor.
Hello?
We can hear you. Seems they cannot hear us. Hello, we can hear you well.
Yeah, I can hear you now. I can hear you now. Yes, can go on.
Okay, you probably had a fluctuation in the internet.
Can I repeat the question?
The question was if there were any other reasons why the oxytocin did not meet the quality standards apart from the storage. Can you hear us? Hello. Dr. Chioma, can you hear me? They've lost the audio, it seems. Dr. Chioma, hello. Dr. Chioma, we can hear you.
Storage for us could be the primary reason because the medicines are manufactured mainly in very good facilities, and some of them fail, some did not fail. So we don't have any other reason for now. Of course, we may have to do further investigation to see the cause, but right now we don't have any other reason. Hello, I can hear you.
Yes, the next question.
Right now, the only reason we can attribute to the failure is storage conditions. Thank you.
We have another question from Patience Coffee. Are there posters on the use?
And also, if you look at our results, the few volume microbiological tests, pH, everything passed. So only the assay due to degradation.
Next question. Are there posters on the use of Amstel for providers in health facilities to guide appropriate use of oxytocin? Hello, did you hear us? Are there any posters on the use of active management of third stage labor in health facilities?
Yes, I can hear you.
Okay.
Hello, Milka, I can hear you.
The question is, are there posters on the use of active management of
Say that again.
Are there posters on the use of active management of third stage labor for providers in health facilities? Are there any posters on the use of oxytocin in healthcare facilities? Have you seen posters in the facilities telling
Okay, ask one.
providers about the use of
Okay,
oxytocin?
okay, I'm sorry, Milka, did you say? Okay, the question says, are there any posters to show the active management of proper management of active stage of labor in facilities? Is that the question?
Yes, that is the question. Are there posters?
Okay.
Did your study
Okay.
check on
I
that?
haven't
Yeah.
I haven't seen. But again, the respondents, I haven't seen any. And one of the major findings or recommendations we made, like I mentioned, outside varying dosage administration, even intra-facilities, people tend to use different things. They could use guidelines from UK guidelines or American guidelines or Canadian guidelines, even within facilities. That was the major finding for us. So I haven't seen any, and one of the recommendations for us was for there to exist a unified protocol for Nigeria. And a major stakeholder, which is society, to have a unified protocol that can say this is what should be used. There isn't any like that. And one of the major things we have achieved in this study is one of the major stakeholders, the Society of Obstetric and Gynecologists of Nigeria, trying to develop a protocol for oxytocin guidelines. Because, like I mentioned earlier, within facilities, within Nigeria, people use different guidelines. So it doesn't exist as I speak. I don't know about posting. Yes, it was something we found out, and it's part of our recommendation, and something is being done as I speak. They were part of the stakeholders at the dissemination, and they're working towards that.
Thank you so much. The next question is that from Sophia Delevi Ori. It is confusing that the pharmacies have the best storage, but the worst quality.
Yes, because it is not just at the point of sampling. If the cold chain is broken before it gets to the facility, it will still be poor quality. So we are not able to identify what happened to the products before it got to the facilities.
Another question from Andrea Baer. Do we know from this study if all or what percentage of the provider facilities had working refrigeration?
We don't have the exact figure, but we can find out. Yes, we know. We can trace it from our data. Yes, but it's not available right now. But most pharmacy stores have, but sometimes they don't have power to power the refrigerators. even in health facilities, sometimes there's no power to power it. So, but we can get that data from our data pool.
Thank you so much, Doctor. The next question from Yabuku Aliyu. As part of your advocacy to the minister, are you considering advocating for the development of SOPs for the use of oxytocin in Nigeria?
Yes, actually, the PQM program funded by USAID has supported the development of the quality assurance policy for the country. We are in the process of making it come live by converting the policy to guidelines and eventually SOPs at the facility level. We are still discussing with funding agencies to make this happen. At this point, it has not happened, but it's in the process once we're able to get go ahead to do that.
Thank you.
I just mentioned, sorry, I just talked about development of SOPs and guidelines for use of oxytocin, at least within healthcare, the healthcare service delivery system, which the stakeholders or the authorizing the body, they are working on that already. So that's in addition to what Chimeze has just said.
Then I have this final question. What was the failure rate in 2016? And what was then between 2016 and the current study to improve storage conditions in particular?
Now, this study was conducted in 2016. So what we have here is the failure rates. But in 2 weeks' time, we are going for another survey to see whether something has changed. Since this study was conducted, with our advocacy, the government has done a lot to change the situation of oxytocin storage. In the next coming months, we'll be able to find out whether those policies and practices are having effect. So we don't know right now the current state. The data you have here was conducted in 2016. But the clinical studies was done a year after, a full-on to the survey. Thank you.
Thank you, Drs. Chimesi and Dr. Chioma, for this wonderful presentation. We have recorded the presentation, and an audio and video link will be sent to all of you. Dr. Chimesi and Dr. Chioma, the microphone is yours to say goodbye to people.
Okay, thank you everyone for tuning in. We'll continue with this survey and study, and hopefully, if you have more questions, you can reach us through our emails.
It was a pleasure having this time with all of you. Thank you for coming on board, and we're very open for questions. Thank you.
Thank you so much. Have a good night. Bye-bye.
Okay, bye from Nigeria.
Goodbye. Thank you.